Now I have the honor and the pleasure of introducing Dr. Brian Rubin. He's going to be our first speaker. He's talking today about EHE 101, what you need to know. And Dr. Rubin is a longtime friend of this community. He is an expert guide for us at the foundation. He gives endless amounts of time to patients and to us, answering our questions. And we thank him for being here today. So I will turn it over to you. I'm going to stop sharing here, Dr. Rubin, and give it to you. Thank you very much, and thank you all for being here.
Okay, thanks a lot, Denise. I'm going to share my screen now. Oh, I got it. Here we go. All right, did that work? Can you see it?
Got it.
Okay. Yeah, thank you. And it's interesting. So we were sort of talking before we came on, and one of us mentioned last night that they woke up in the middle of the night and heard the theme song from Gilligan's Island. And I've been with this group since the very beginning. In fact, I remember maybe about 14 years ago, I got a call from Jane Gukovich of all people, and telling me about her son and this disease, and she'd seen or heard about some work we were doing. And I guess I thought I was probably going, for at most a 3-hour phone call. And, here we are almost 15 years later. So I'm on the island of EHE and quite happy to be here, quite delighted to be here, and quite honored to be here. So thanks for the honor of being able to present today. We're going to talk about some really basic kind of stuff about EHE, and hopefully this will stimulate some questions. I do want this to to be an informative talk for you. And Denise gave me some pointers for some stuff that I wanted to talk about this year that I didn't mention last year that might be important to you. But if you see anything on these kind of talks that don't make sense, or that you want more information about, feel free to reach out, and I'm happy to explain it to you. So let's get going. Okay. All right. So just first of all, EHE is classified as an ultra rare cancer. Probably everybody on this call knows that already. The incidence is estimated at less than 1 in 1 million people. That's the definition of an ultra rare cancer. And it is a malignant vascular neoplasm. So that means it's a cancer, a sarcoma, sort of a mesenchymal tumor with endothelial differentiation. So when we look at these things under the microscope and do tests on them, we see that they have vascular differentiation. Now, what's with the name? So epithelioid means the cells are round, and hemangioendothelioma is definitionally a cancer with vascular differentiation. So it's a cancer with vascular differentiation composed of round cells. One of the things that came up last year, apparently, is that there's a lot of confusing names out there. And I agree. I practice in this field, and there's many, many different kinds of vascular cancers. In fact, I have a talk where I show all the names, but there are some confusing stuff here. So not to be confused with epithelioid sarcoma. Epithelioid sarcoma has nothing to do with endothelium, we think. Actually, we don't understand it fully, but it's a completely different entity. This is really confusing. There's epithelioid sarcoma like hemangioendothelioma. So that's a endothelial hemangioendothelioma thing that looks like epithelioid sarcoma. Again, a different neoplasm. That also goes by the weird name of pseudomyogenic hemangioendothelioma. It has 2 names. Now there's epithelioid angiosarcoma, and that's important because epithelioid angiosarcoma needs to be distinguished from epithelioid hemangioendothelioma, and they can look similarly, but a very different disease that has a much worse prognosis than epithelioid hemangioendothelioma, and in fact has a totally different therapy. And then there are other hemangioendotheliomas, so things like rediform hemangioendothelioma, Kaposiform hemangioendothelioma, composite hemangioendothelioma. They're all individual disease. So just because it has the name hemangioendothelioma in it, it doesn't mean it's EHE. And EHE, not to be confused with these things. If you ever, again, have a question about what your diagnosis is, happy to help you out. So, just to get back, I always like to show this slide. This is where EHE started. Here we have Franz Enzinger on the left here. This man, he is the father of soft tissue pathology, essentially. This is his first protege, Dr. Sharon Weiss, who's an amazing pathologist in her own right and retired recently. And there they are sitting at the microscope there. They're both looking at the same slide. And Dr. Weiss assured me that this could have been taken at the time they were looking at and coming up with the concept of epithelioid hemangioendothelium when they published their first paper on that in 1982. So this entity didn't even exist really before 1982, just to show you how rapidly we've kind of evolved here and with this disease. Now, clinically, it's slightly more common in women. There's an incidence that peaks in the 4th and 5th decade. It's very rare in children, but it does occur in children. And it can arise at any anatomic site. That means anywhere in the body. We've seen EHE literally everywhere. Liver and lung are the most common sites. And then there are different clinical presentations. Patients can present with a single lesion. That's most often common of skin lesions, or multiple lesions in one organ, that's local regional metastasis, or multiple lesions involving multiple anatomic sites, that's systemic disease, systemic metastasis. 50% typically involve lung, liver, and bone. And then the presenting symptoms include a lot of asymptomatic kind of presentations of pain, for instance, a palpable mass, weight loss, kind of very non-specific presentations. Okay, and then prognostically, many prognostic factors have been proposed, but none are really well validated. And Michael Wagner published a paper on this last year. I was privileged to be a participant on that paper. So we do know that serosal or pleural involvement with effusions have an adverse prognostic factor. So when there is an effusion, it tends to be associated with a worse prognosis. Fever, weight loss, fatigue are associated with a worse quality of life. Many of the patients on this call will be able to relate to that. Anemia may be a negative prognostic factor. We're not totally sure. And then the clinical behavior is extremely variable, from indolent, slowly progressive disease to very aggressive disease with a lethal clinical course. And again, I've learned a lot about this disease from talking to all the patients about it. Now, disease surveillance at this point typically consists of serial sequential imaging. There are some projects being proposed out there that would perhaps follow things in plasma, but they're not really the standard of care at all. At this point, we're just talking about looking at images and seeing whether the lesions are growing or whether there's an increase in the number of lesions. Now, importantly, if there's anything that I want to communicate, but I feel like I'm probably preaching to the choir here, but maybe there's some new patients, we do recommend management of EHE patients by a multidisciplinary treatment team. That means a team that's composed of surgeons, of oncologists, of pathologists, of radiation therapists, of everybody that would take care of a patient on the same team, all with experience in treating patients with this very rare disease. And that's because experience is really, really important. Working together as a team at a very high level is very, very important. Okay, so let's talk about the pathology. So this is an epithelioid neoplasm. Remember I said it was a epithelioid hemangioendothelioma. And it has this very unusual stroma. And actually in my laboratory, I'm not going to talk about it today, but we are actually very interested in that stroma. And we've studied it extensively over the last several years. Hopefully we will have a publication on that later this year, but we do think it's important in terms of the behavior of these cancers. And again, they show vascular differentiation. That means it's positive by immunohistochemistry. The three most common stains that would be used here would be CD31, CD34, or ERG. They are all endothelial markers. They're not absolutely specific for endothelium, but they mark endothelial cells very well. And we're going to talk a little bit about pathology report in a second. I'll get into that there. There's two genetic subsets here, subtypes. The first is the WWTR1 CAMPTA1 gene fusion that's present in about, let's say, 95% of the cases. This is so rare that I think these numbers are always going to be slightly approximate, but this is probably not far off. And then CAMPTA1, immunohistochemistry, is a surrogate immunohistochemical marker for the fusion. And then YAP1 TFE3 gene fusion is the other fusion that we see, and that's much rarer, maybe 5% of cases. And then TFE3 is a surrogate marker for that genetic subset. Here is a picture of an EHE. This is from a liver transplant patient, and you can see here these three nodules that are highly visible. These are all EHE nodules, and this is very typical where they have this kind of fibrous white center surrounded by really what is a mix of tumor cells and liver. That's a pretty typical picture for EHE. Here's what it looks like under the microscope. So here's that weird stroma, all this pale pink stuff that I'm showing you here. Hopefully you can see my pointer, is the stroma. These are the tumor cells here, the culprits, these little sort of round epithelioid cells. Can you see how they're round? And then occasionally there's a red blood cell that's associated with these. I'm not sure if it's a coincidence or not, but anyway, we do frequently see that. And notably, this is a poorly differentiated tumor in that it's not forming blood vessels. I don't think anybody here can see an actual blood vessel. So it's a very primitive neoplasm, primitive tumor. Here's CD31 staining. So this would be, you know, if I saw this case under the microscope, I would say, well, that looks like EHE, but I want to be sure. And so what I would do is do some staining with immunohistochemistry, and CD31 would be at the top of my list. And here's nice staining of all those tumor cells that I just showed in the last slide. This would be ERG here. And here's strong nuclear staining with ERG. And then I mentioned that CAMTA1 is a surrogate for epithelioid hemangioendothelioma for the fusion, WWTR1 CAMTA1. CAMTA1 is a protein that's not expressed normally in the adult organism. It's more developmental, and it's expressed a little bit in the central nervous system, but certainly not in any kind of tumor. And so CAMTA1 staining is a very good surrogate marker for this disease. And here's just another case of EHE here on the left. Now, to talk about the pathology again. So again, I recommend review by an experienced soft tissue pathologist. And the reason is that this is a difficult diagnosis to make if you haven't seen it before. Pathology, histology is not black and white. It is a lot of gray, and experience matters. Experience is extremely important here. And so you want somebody who's got a lot of experience, who looks at a lot of sarcomas, who is active in the field to make this diagnosis. And by the way, it's very easy to get a second opinion in pathology. People think they're going to be putting their pathologist out, or that, upsetting somebody by asking for a second opinion. Pathologists half the time don't even know that their cases are being sent out. And even if they did, they would agree with you. They would recommend getting a second opinion. And people send me a lot of this type of material, pathologists, because they want somebody who looks at these a lot to look at them. There is a big differential diagnosis. It includes a lot of different types of carcinoma, but especially breast cancer. Lobular breast cancer can look just like EHE. And as you can imagine, if you have EHE of the breast, this could be a very significant problem. Mesothelioma would be a mimic. Epithelioid sarcoma, other vascular tumors, including just regular forms of hemangioma, all the different kinds of hemangioendothelioma I talked about, pseudomyogenic epithelioid sarcoma, et cetera. And then angiosarcoma, I mentioned, epithelial angiosarcoma, very important to distinguish these things from each other. So how is EHE diagnosed? So as I just spoke, it's diagnosed mainly by histology and immunohistochemistry, but we also use molecular methods. And when people talk about molecular methods, it's not like molecules, it's DNA and RNA. It's kind of a bit of a misnomer. But molecular pathology is essentially the study of DNA and RNA. So we can use a technique called fluorescence in situ hybridization, otherwise known as FISH, or gene sequencing. Now, when you get your pathology report and it has the diagnosis of epithelioid hemangioendothelioma on it, at a minimum, I want that report to have some immunohistochemistry on it, including some of these endothelial markers. I would say at least 2 endothelial markers is important. So CD31, CD34, and ERG are most commonly used. These are solid endothelial markers. You want to see at least 2, preferably 3 markers, just to be sure, first of all, that it's an endothelial tumor. That doesn't mean it's EHE though, right? We don't stop there. What we then want to go do is something more specific. So now, minimally, I want to see either CAMTA1 or TFE3 being positive. If CAMTA1 is positive, that means you have a WWTR1 CAMTA1 gene fusion. If it's TFE3 positive, not perfect, but it has a pretty high likelihood of being a YAP1 TFE3 gene fusion. Then, it's good to get genetic confirmation. And we have two ways of doing that, as mentioned before. So FISH for CAMTA1 or a TFE3 gene rearrangement, or RNA sequencing. And I think RNA sequencing is preferable. Looking for WWTR1 CAMTA1 or the YAP1 TFE3 fusion. If you see those fusions, you've got everything else there, then that's really a very solid diagnosis of EHE. And as people know, there may be some new patients here, but there's patients who've been with us for a very long time now. This journey is long, and you want to make sure you have the right diagnosis. It's absolutely critical, as you can imagine, to have the right diagnosis as you move through the medical system and people try to understand and help you along the way. Now, this often comes up where people will say, Dr. Rubin, should I get, I don't want to name names, but, this very kind of large, expensive sequencing for my tumor? And the answer from my perspective is it's not required. You don't need hotspot sequencing. You don't need whole exome. You don't need whole transcriptome. It adds information, but these are genetically quiet tumors. They tend not to have a lot of other mutations. And at this point, we're not really using that information at all, but it could add, $5,000 or $6,000 of expense when you really don't need it. And again, if you're considering it, you're not sure what to do, give me a call. I'm happy to talk to you about it. The reason, of course, that you want to do all this, I mentioned earlier, is there's a significant number of misdiagnoses. And it's not just among the neophytes who don't see these cases every day. We actually ran a clinical trial not that long ago in EHE. We just published the results of it, by the way, in Clinical Cancer Research. Scott Jutzi was the oncologist who led the trial. He's the first author. And I reviewed all the cases for that trial, and even cases coming from the best centers in America, we had a significant number of misdiagnoses. It wasn't like every case, but it was, 3 or 4 from the total of 30. So it was around 10% of the cases were not EHE when I reviewed them. And I'm absolutely certain I'm right on this because I did a lot of studies to prove that these cases were not EHE. Why do you want, and then finally, beyond just getting your diagnosis right, why do you want your gene fusion? Why do you want to know that? And the reason is it's going to increasingly be required for entry into clinical trials that target either WWTR1 CAMTA1 or YAP1 TFE3. So knowing your gene fusion could facilitate your entry into a clinical trial with a new drug that actually targets the fusion protein that's encoded by those genes. Okay. Imaging is going to be important in your workup. So once you've got a diagnosis of EHE, or probably along the way, you're going to have some of these studies done anyway. The baseline staging is just whole body imaging. You look at either CT, MRI, or PET CT. You can do any of these studies. CT would kind of be the most minimal thing. I think most people these days are getting PET CTs, and that shows you where the tumors are within your body. Very important to know the distribution of tumors. And then for progression assessment, CT is used typically, and we just follow the pre-existing tumors, watch them, and we look for the appearance of new lesions or effusions or growth of the lesions that are there already. Now, apparently there's some terms that have caused some confusion, so I'm going to go through them one by one. So lesion, what do I mean by lesion? I use that terminology a lot, and I kind of get that. So in the context of EHE, when I say lesion, I'm talking about a tumor, a mass, a piece of that cancer that you have in a particular lesion area of your body. So I might say there's a lung lesion. That means you would have a tumor in your lung, an EHE tumor. Now, local regional, this gets a little bit confusing. So what is local regional? What do I mean by that? So local regional means metastasis within a structure. So that would mean if you had a lung tumor, that you would have metastasis or spread within the lung or within the lymph nodes that are adjacent to the lung, but not really beyond that. Unifocal is a single tumor. So again, I mentioned that with patients with skin EHE and superficial subcutaneous EHE, they frequently present with one tumor, and those patients have a great prognosis because with one tumor, you surgically resect it, that very high probability that the patient will do well. Distant metastasis, so that means spread beyond the initial site. So that means If you started off with a lung tumor, now you've got tumor in your liver, that's a distant metastasis. If the tumor went to the brain, that would be a distant metastasis. If it went to the GI tract or into the abdomen, distant metastasis. To the heart, it's just so it's spread beyond where it started, but to essentially a different site. Resectable versus unresectable. So as I mentioned, with a skin or a subcutaneous single tumor, that's virtually always going to be resectable, which means you can remove it. It can be removed. Unresectable is patients with many, many tumors. You can't get them all without causing significant harm to the patient. Remember, doctors have the ethical principle of do no harm. So we try not to resect patients that are unresectable because we know we're not really helping them and causing a lot of morbidity. Active surveillance, that means we are actively watching the patient, looking to see what happens to the tumors. Are they growing? Are they spreading? Are there more tumors? And you will get that typically with, if you have EHE, you're getting a scan every 3 to 6 months, perhaps longer, as patients kind of go out longer and the tumors maybe aren't as active. We will follow less actively, but it means to actively follow you along the journey and do CT scans for the most part. Asymptomatic metastatic disease. This is how many EHE patients present. Get into a car accident, they take a picture of your liver and your abdomen and say, wow, you've got widely metastatic cancer, lots of tumors. So that means you had no idea that you had cancer, and then you had no idea that it had spread all over your body. And that happens not just with EHE, that's actually a frequent way for patients to present. Symptomatic disease. So asymptomatic means no symptoms. You have no idea you've got it. I could have an asymptomatic cancer right now. That means I'm sitting here, I have no realization that I have it, and take lots of pictures of my body, find something. Okay, now I have asymptomatic cancer. Symptomatic means it causes problems, some kind of pain. Maybe you're feeling very tired because you're anemic, you're bleeding, and you don't know about it. But you would have symptoms attributable to the cancer. And then, some patients present saying, I feel really sick, I'm losing weight, I have a lot of pain in my liver, it's frequently hurting and whatnot. That means you have symptoms. And then stage 4 disease is widely metastatic. So that means it's not only spread, but it's spread to a really distant part of the body. And depends on the cancers how we stage them. It's a little bit different for each cancer. EHE typically presents with stage 4 disease and wide metastasis. Okay, so what are some of the unmet needs? So, due to the unpredictability of the clinical course and lack of effective medical therapies, research is really sorely needed. That's where I come in. My laboratory really focuses a lot of our attention on EHE. It's one of the only diseases we study. Denise mentioned it earlier, patient registries are incredibly important. The EHE Foundation plays a critical role in following a lot of patients with their registries. So if you haven't joined the registry, please do. It's important to understand this disease. Biobanking of EHE samples. Again, Denise is doing a great job with the biobanking, but we need more samples. We will never not need fresh tumor, and that's what the biobank is doing. It's banking fresh tumor, and we can use that to develop biological models, which is my last point. We've made a lot of progress in the development of biological models. However, more progress is always needed, and we are actively working on that. So let's just talk really briefly about biology and model development. I will give a plug for Ajay Babadi, who from my laboratory is going to be talking about some of our research a bit later. But essentially, this is how we understand how TAS-CAMTA1, the gene fusion, functions. It's the same for YAP-TFE3. And so the Hippo pathway, you may have heard about this. This is a genetically conserved or evolutionarily conserved pathway. And the major role of the Hippo pathway is to regulate the localization of TAS. And I should say that TAS is the protein that's encoded by WWTR1. So WWTR1 CAMTA1 is the same as TAS CAMTA1. And so the major role of Hippo is to regulate TAS. But in fact, when TAS is fused to CAMTA1, it can no longer regulate it. This is something called a transcription factor. So TAS-CAMTA1 is a transcription factor, which means it actively makes genes express their RNAs and proteins. And so what happens with TAS when it's dysregulated is it makes this very cancer-related transcriptional program which drives EHE. And so it needs to do this by binding TEAD4. TAS-CAMPTA1 can't bind to DNA by itself. It uses this other protein called TEAD4. That interaction of TAS-CAMPTA1 with TEAD4 is what's driving all this drug regulation with TEAD inhibitors. It's the basis of the idea that TEAD inhibitors will work in the inhibition of TAS-CAMPTA1 that drives EHE, and why this is a really good target strategy for this disease. We also showed, and this was the work that was published in 2022 in Clinical Cancer Research by Shuang Ma from my laboratory, that in fact, proteins like CTGF are part of that transcriptional program I mentioned, very critical. It's a protein that's secreted from the cell. It then binds to the signaling transduction network and activates the MAP kinase pathway, personified here by MEK1 and 2. And that was the basis of the clinical trial that we ran and just published in Clinical Cancer Research with Scott Schutze as the first author, using trametinib, which is an inhibitor of the MAP kinase pathway. So we've been able to genetically engineer now mice, which get this disease. It's so hard to get hold of human tissue. One of the strategies we always use in doing this kind of research is develop genetically engineered mice models. That means we make mice which express the fusion, WWTR1, CAMPTA1. They all develop tumors which look just like the human tumors. Here they are over here. Here they are on the left from mice, and then on the right side, and they look just like human EHEs. In fact, I've shown these to a number of pathologists under the microscope and said, hey, I've got this hard case. Would you guys look at it? And they look at it, they think, wow, maybe that's EHE. And then I showed them some immunohistochemistry. They're like, yep, that's EHE, all right. So it looks just like the human one. We could actually take those cell lines or those tumors and make cell lines out of them. So we have 3 cell lines that we've made. We have a few more that are brewing. They're not quite ready for prime time yet. But now we can make cell lines, and what cell lines are is they're just cells that can grow indefinitely in a dish. This is really a nice tool that we can use now to study EHE because we can manipulate those cells, do things to them. We can do drug treatments. We can play with their genetics, do all sorts of things to develop more and more tools. And so we're deeply into the development of this system now. We can also take those cell lines and re-implant them in mice. So if the question is, what happens when you treat, like let's say we identify a drug using our cell lines, and now we want to put those and test them in an organism, we can actually inject our cell lines into mice, they grow tumors, and then we can do that sort of testing. And the tumors, when they grow, they spread just like they do in a patient. And so it's, again, a very, very nice model of being able to study that. It's not the only model, but it's one very useful one. And here's just something we did with drugs. And so here we have trametinib. I showed you, these are the 3 different cell lines. What you can see here, the blue line is no treatment at all. And you can see as you start giving the drug to this one cell line we call 3.6, you're inhibiting the MAP kinase pathway. Essentially, the cells stop growing. That's why these bars are getting shorter. And it works on all the lines. Now, looking below, MGH-CP1 is what's called a tool compound, but it is in fact a TEAD inhibitor. That's why I'm excited about TEAD inhibitors. They actually work in our cell lines just as you thought they would theoretically, and so they inhibit the growth. And again, the blue bar is no MGH-CP1, and the black is a lot of MGH-CP1. And you can see that we can suppress growth very strongly with this tool compound. And then again, there's some clinical trials out there now looking at TEAD inhibitors, and many of the sponsors of this meeting today have clinical trials for TEAD inhibitors. And again, I can't state this unequivocally enough. I think that TEAD inhibitors are going to be a very good solution for the treatment of EHE. I'm not sure who's going to win the race to get there, but a lot of development in this space. And in fact, we even have a project with the NCI, the next program with one of our collaborators here at the Cleveland Clinic, to develop our own TEAD inhibitor program. So we're working on it too. And just to say, these are just acknowledging the people in my lab who do all the work. Here's the funders you can see on the right, including a lot of EHE Foundation, not just here in the United States, but over the UK and Australia, Cravat, People have been very generous. A lot of patients have just given personally to my laboratory, and I want to thank you for that, because it's money. It does take money to do all this research. I'm not here soliciting funding from you today, so don't mistake that I'm asking you for funding. You've been generous and provided. We actually at the point now where we've used a lot of the money that developed these things, and we can get grants now. And so we just got another R21 grant from the NIH. We have the NCI Next funding, and we're actively still seeking additional funding. You can never have enough funding, but we have been able to transition from all the generosity given by this group to be able to now apply competitively at a high level for grants. And again, we're very, very grateful for the support of this foundation in making all that happen, as well as the other people, other foundations and funders here on this slide. Okay, I think I'm done, and I'm happy to answer any questions that you might have at this time.
All right, yeah, thank you very much, Dr. Rubin. And we actually have several questions that came in. We won't have time to ask them all live, but perhaps if you have a little time afterwards, they can be asked in the Q&A box if you're willing to take a look at some of those.
Sure.
Throwing out one of the questions, there was a question about the size of the tumor related to aggressiveness. Can you have sort of smaller tumors become aggressive, and is there any correlation between size and aggressiveness?
Yeah, that's a great question. And so I would say that I don't think we've answered it rigorously, but in fact, I don't think size dictates aggressiveness in EHE. I think you can have very small tumors that spread very quickly and can cause all the bad things to happen and be very aggressive.
Excellent. I guess we have time for one more quick one, and then we'll move on to our next speaker here. There was a question about whether analysis of the DNA markers is useful over time to evaluate either treatments or the progression of the disease. With other cancers, we see people do blood tests and analyze, or even biopsies and analyze the genetics over time to see changes of disease status or treatment effectiveness. Is there anything like that for EHE?
So we've actually been pushing the idea that there is a genetic progression within EHE. Frequently, it's loss of a tumor suppressor gene on top of that. I think we've more or less proven that, but in fact, it's hard to translate that into a clinical marker. I think a formalized study would be really interesting to look at genetic progression in a group of EHE patients over time and do that. It's actually fairly difficult to do because if you think about it, you'd have to go in and re-biopsy patients. And so I think what we really need to do is develop a blood test where we can follow the genes out in the it would be plasma that you'd analyze. And if we can get that test set up so that we can do some deep genetics on that, and that technology is really coming along. So this kind of trial could be very feasible, I would say, within a year to over the next few years. I think that would probably be the way to do it. But yeah, I think it's probably right that there is genetic progression, but we need to actually rigorously study it and understand it so that we can help clinicians, the people who treat patients, be able to say, this patient has this marker, that means they are probably very aggressive. We need to move them onto a different therapy or a different clinical trial. And we just don't have that kind of linkage yet, but that's the idea, and that's where we want to go.
Excellent. Well, thank you so much for your time today.